Good evening, respected guests and colleagues, and good evening to all my friends here at Bless Homes and the management. It's a pleasure to welcome you to our first panel discussion of the day, focusing on integrated geriatric care, medical, mental, and social well-being. Geriatrics is a specialty, is still in the infant stage in India. In the good old days, joint families took care of the aged, and one did not give it a second thought. However, with the younger generation seeking jobs outside and nuclear families having taken root, the aging population and the needs of the older adults become increasingly complex, as we all know. Health is not just an absence of illness for the elders, it's about maintaining medical stability, mental sharpness, and emotional resilience, and strong social connections, as so well put by our keynote addresser, Dr. Matthew Abraham. Health is not just the absence of illness. Our conference theme, Together for Graceful Aging, Advancing Geriatric Care through Collaboration, reminds us that no single discipline can address all these needs alone. An integrated approach combining medical treatment, mental health support, and social engagement is essential. Today we are joined by 4 distinguished panelists whose expertise covers these interconnected areas. They bring perspectives from clinical practice, mental health, community programs, and social work, offering us a comprehensive look at how we can truly integrate care for the elders. My first question, let us start with Dr. Sunny Orathel. I hope I've pronounced your name correct.
Yes.
Consultant in the preventive health checks. Preventive health checks are often undervalued in elder care. From your perspective, doctor, could you please tell us in brief what specific health checks you would recommend for the elderly and how often should they be done?
Thank you, ma'am. It's a very difficult question to answer because as age advances, the investigations vary. The first thing what we have to see is that whether this aged person is having some other comorbidity or whether he is already having some disease. If not, then we will have to go for the routine checks and all. Of course, at this age, we have to go for the simple tests like a routine blood examination. It has got its own value. Why? Because even a low hemoglobin may be a pointer towards cancer diseases. And of course, ESR may be raised, and that may be the first indication to detect or the first indication to see whether the patient is having multiple myeloma, which may not be addressed earlier. So routine blood examination is of paramount importance, even though that is the basic thing. Routine urine examination, again, first time that may be detected for sugar or albumin and all. Then renal function. As age advances, naturally, renal function may come down. He may not be aware of the thing that he is a person or a candidate for renal disease and all. Especially an old person with the prostate and all. He may have a renal problem, but which is not detected or he is not aware of the thing. Just like that, liver functions. Fatty liver may be there, or even otherwise liver enzymes may be there. And because of raised liver enzymes, sometimes some gallbladder stones or some malignancy with related to liver or gallbladder may be there. So that may be detected with the liver function test. Again, thyroid function test. Thyroid, just now, Madhyaparan sir mentioned about aging, dementia and all those things. Some treatable cause of dementias are there. TSH, thyroid function test may be, thyroid functions may be altered, and that may be detected for the first time. So it has got its own paramount importance. Again, lipid profile. Aged persons, they may be prone for cardiac disease and all. Even otherwise for cerebrovascular accidents, cholesterol has its own significance. Then most of the people nowadays, we are seeing that they are having a vitamin D deficiency. So that also has to be addressed. Again, serum electrolytes, sodium. A lot of the people after the age of 60, suddenly they become unconscious or loss of consciousness or altered consciousness, maybe because of hyponatremia. calcium is of paramount importance. Calcium may be raised in certain conditions, certain malignancies, but calcium may be low in osteoporosis, osteopenia and all. So serum electrolytes is of importance. One thing that has to be specifically looked for male patients is prostatic specific antigen, PSA. PSA, if it is raised, that may be an indicator of a prostatic malignancy. So that has to be looked, and it's one of the treatable cause of a treatable condition in cancer. Then specific thing that has to be addressed in females is one is mammogram. If not done, has to be done. No doubt about that. Then the other thing is gynecological examination for all females. And for all people after the age of 60, if not done, has to undergo colonoscopy and esophagoscopy. And if possible, and if facilities are available, bone mineral density also has to be looked. These are the things that has to be.
These blood tests you were talking about, how often would you suggest it?
That depends. If everything is normal, you need not go for a blood test every 6 months or so. If everything is normal, then we have to repeat it after 1 year or so. But if it is borderline, say for example thyroid is borderline, sugar is borderline, naturally we have to test after 3 months. That depends on the primary value which is there.
Thank you, Doctor. Dr. Anusree, Dr. Jyotish Nair, we are seeing that India is heading towards becoming a diabetic capital in the world. An aging population makes this scene more challenging. In short, what advice would you give to educate the healthcare workers, the general public, as well as the health professionals to face the challenge?
Thank you, ma'am, for the question. In fact, as you have mentioned, the aging population creates lots of problems in this aspect, because even though it's rare to detect diabetes or these things later in part of life, in most of the Indians, what happens is that almost all these diseases start somewhere in their 40s and then they progress. So what we are seeing at 65 or 70 may be the result of 20 or 25 years of this illness down the lane. So that creates actually, maybe diabetes is one of the problems, hypertension, dyslipidemias, that is abnormal cholesterol profiles, hypothyroid, obesity, then the, as sir has mentioned, osteoporosis. So all this complicate the problem. So that's where we start actually, because detection of these illnesses has to be done earlier, and management has to be properly done so that they don't develop complications at 65. We want people to be, as we know, the life expectancy has increased. So if a person is a detector of diabetes or any of these illnesses at 40, he should live a healthy life till 75 or 80, or if more than that, till that age. So just not detection. We have to actively check, detect, manage them properly, so they live a long life without complications. For that, actually, first is detection of this screening. So starting from 40, or if they have risk factors, maybe earlier also, we have to screen people to detect all these things. Obesity is a big problem that is coming up in India as well as the Western world, starting from childhood. So those who are obese have all these problems adding up. Anyway, we have to start screening. So the message to the general public, not only just health workers or all who are actively involved, for all those who are, all those people, detect all these diseases as early as possible, then manage them properly. That is most important, not just detection. Because once you detect, take advice from your doctor, take the proper lifestyle modifications, follow the medicines properly, go for the routine checkups, and see that you are not developing complications. If you are developing complications, start treatments accordingly. And then at the end of maybe 25 or 30 years, still you are healthy and you don't have much problems. So all these things have to be done properly. And one more small advice is, we are in a scientific world and science is guiding us, technology is guiding us. Please don't follow any of those unscientific treatments, modalities or managements which you yourself cannot logically explain, or magic remedies. There are scientific treatments and please follow them so that you don't end up in a worse condition than where you start from. Thank you.
Thank you, doctor. What I have seen is, people don't follow up very well. So that is one of the causes for deterioration of the diabetic conditions. Thank you so much. Now, my next question is to Dr. Anusree. She's a geriatrician. Doctor, would you say that with age there are certain physiological changes also taking place in the body? What makes geriatric medicine different from general medicine? And how does a geriatrician approach treatment, planning to address the unique physical, cognitive, and emotional needs of the elders?
Okay, thank you. Thank you for the question, ma'am. So for the first question, yes, there are a lot of physiological changes that that comes with aging, especially in cognition and in organ by if you are going, the lung elasticity changes, heart elasticity changes, and there is reduced mass, that is muscle mass, and even the cognitive reserve also decreases with aging. So there are definitely different physiological changes that happen. Second is that how do we approach? So when as a geriatrician is concerned, we have I would say three categorizations. So the first categorization will be like we have a preventive approach where definitely we'll be guiding the patient regarding what preventive strategies that they can take, especially lifestyle modifications. Then immunization, because most of the patients are not very aware of the immunizations that are especially for pneumonia. And third will be the fall preventive strategies. How can they prevent further memory loss, things like so. Preventive strategies are there definitely. Then curative strategies. So curative strategies are basically which we give acute care and chronic care, where we deal with diabetes, hypertension, chronic illnesses, and multimorbidity, which is very important in geriatric aspect. And then there is something called as a planning aspect. So the planning aspect is something that not everybody follows. That is there is something called as a living will or the advance directive. So that is where we have to plan the further care of the patient. Like goals of care has to be defined. What do we expect from the patient in the further planning? So all these things are the main categorization of geriatric as a geriatrician. But this is not a one-man show. This is a holistic approach. So in order to do all these, we need a physiotherapist, we need a social worker, we need a psychologist, and we need a comprehensive approach to the patient, because it's not a patient, it's a person. So we have to comprehensively and holistically see him as a whole. So I think these are the major things that a geriatrician has to do.
Thank you, doctor. That was quite conclusive. Dr. Jose Antony, how does social isolation, both forced as well as a choice, lack of engagement, affect elders' overall health? And what community-based models have you seen work well to keep them socially connected and active?
Thank you. Thank you, Bless, and as well as thank you, the moderator and the audience. It's quite meaningful question that how the social isolation as a forced experience as well as a choice of life. Really voluntarily people become insulated themselves from the social network. Because as Madhya Prem sir said, just do or be concerned about three things: attitude, attitude, and attitude. And that is very important. And I would say this attitude may be defined in this way: attitude of hope, attitude of basically confidence and being connected. That is fundamentally the issue of isolation comes in. If I have a hope, I have a lot more things to do. As woods are lovely, dark and deep, but miles and miles I have to travel, or dreams and dreams I have to fulfill. At any age, that is something which make us lead our life much more comfortable. So how we instill and maintain hope in our life. Death is one way a hope, because we have to prepare ourselves. I'll come to that maybe if possible later. And second is confidence to face. The most difficult thing we experience to face is our death. That is, as he said, is the most certain thing in life and most uncertain thing in life. As we grow in age, we have a feeling that we are getting closer to our end of life. So how we confidently face that? So how the social network or the community make the elderly really feel hopeful and confident to face that situation. And the third thing, how you really become hopeful and how you really become confident. The process is being connected. Being connected with the beloved ones, being connected with the neighborhood, being connected with the general community, being connected with the entire social world. So how we do that? As Dr. Anusree was talking, geriatric care requires social workers, psychologists, physiotherapists, and good human beings around them to be connected. And in the modern world, I believe being connected is not necessarily physical, because we have a number of technological devices where you feel connected. It's not necessarily that you are being connected with the proximities alone, but you can be connected with any space in this social order, or maybe even with the geographical space. So most of the people may be living here have their beloved ones abroad or in other cities in India or across the globe. So being connected with the beloved ones, being connected with the neighborhood, being connected with, maybe we all have a childhood memories and our basic roots in a village where we were born and brought up. And maybe we are living here, maybe we may be living somewhere else. But how we can rebuild that connectedness to our roots, our neighborhoods, our beloved ones. As he said, connected with the spouse, connected with the friends, connected with the children, grandchildren and all. So any geriatric care model should have this possibility of making hope in them and making confidence in them, and definitely a beautiful space of being connected with. We have many community living models that has been practiced in Kerala. Bless is one model, but maybe for the people in the in a world where they have much more financial or financial capacity to invest, we have lot more layers in the social order, where we want to have much more socially committed voluntary systems, maybe by religious people, maybe by the volunteer organizations, or maybe by the political organization, and as well as we have county models as we practice in Europe or in UK. In Kerala also we may be able to bring in these spaces for them by the government systems also. There is one model which is being created by one of my classmates. They are both of them are my classmates, husband and wife. They have made a simple model in Calicut, which they call it Tarawad. Tarawad is a nostalgic word for any Malayali, getting back to our family roots. And what they do is they have a space given by the Calicut Corporation. Every day these people can come there. They can. That's a maybe in the childhood we talk about kindergarten, or we talk about a daycare center or something. So this is a daycare space. So every morning they have a vehicle to collect them. They come to the common space. They play, they dance, they do many things. Sometimes they organize a picnic and they get connected. They have something to do with that. And by evening they will get back. If they want to have an assistance, there are people who go and do. And one of the beautiful things I have seen is, if some of them are sick, others in that group serve as bystanders sometimes, because they may not have their children with them. So they feel we are doing something very positive, connected, belonging, hopeful, and confident to face the rest of the life. So that is, we have n number of models, that daycare models, living models, or network communities coming in. As he said, a gated community where there are people living like that. Even the corporates are really coming in and investing a lot in this area to get these type of communities being built with. So there are different models working in. Yeah.
Thank you, Doctor. Actually, if I may say so, in Bless we have both the models. We have a Shanti Bhavan where, you know, they are taking care of the lesser end of thing, as well as here the staff are so committed and they involve the people, but still there are some people who don't want to get out and socialize. So I mean, how they're stubborn.
Yeah, just to add to this, sometimes we have people from the lower ladder of the socio-economic conditions, and they have a very serious gut feeling with them. At the age of, at this age or at this stage of our life, we feel we are forsaken and we are at the mercy of somebody. So I think the government machinery should come into that, because the biggest problem we have to face in the next maybe 2 decades or 3 decades in Kerala will be this.
Thank you, Dr. Sunny again, please. With an aging population, we do see an increase in respiratory diseases like COPD, asthma, pneumonia, etc. Many elderly are not very ambient, and that also probably contributes to this condition. And your valuable advice on some of the following: dealing with common respiratory diseases in the elderly, preventive measures, care on this aspect in a patient who is confined to bed.
The first and foremost thing is that we should identify whether the patient is having genuine COPD or bronchial asthma. Why I am telling is that as age advances, the elasticity of a lung will come down. So naturally, yes, she has mentioned it, naturally there will be a little bit of breathlessness. So all breathlessness need not be COPD and all breathlessness need not be asthma even. So that is one part of the story. Of course that both these are respiratory conditions. And the first thing we have to understand is that lung is the only organ that is exposed to the atmosphere. All the other organs are contained in the body. So naturally there will be infections. That possibility is there. But the thing is that we have to differentiate between these breathlessness with cardiac breathlessness. Most often what happens is that aged people think that everything is asthma, everything is COPD and all, even when they have some sort of these ailments sometime past. So the first thing we have to do is that we have to differentiate between cardiac asthma and respiratory illnesses. So for that, I didn't purposely I didn't mention about ECG, echocardiography and TMT and all. So the first thing we have to do is that take an ECG, take a 2D echocardiography and TMT and a chest X-ray. So rule out cardiac thing. So if it is not cardiac, then we have to address COPD. Then in case of COPD, it's a somewhat stable condition. So there are medications and there are regular treatment for that. If it is a bronchial asthma, again, very good medications are there. But in bronchial asthma as well as COPD, there may have exacerbations and like that. So what we have to do is that most often these people, aged people, will have this diagnosis earlier and they may be in medication. The first and foremost thing is that they have to continue with the medications, especially for COPD patients. Bronchial asthma patients, they can at some point of time they can avoid these medications and all. And of late we have got very good inhalers. And the thing is that most of the people are really afraid of taking inhalers. Inhalers, even for COPD and asthma, inhalers are the treatment of choice. Very good inhalers are there, different combinations are there. So once somebody, physician or a pulmonologist diagnoses it as COPD or bronchial asthma, they have to continue with these medications. And oral medications also may be there. And the second thing is that we have to prevent these exacerbations. For that, we have to avoid unnecessarily exposure to dusty areas and all. And they should avoid going to these crowded places also. So if possible, better not to attend these festivals and better not to attend these melas and all. And family functions, of course, they can go, but with mask and all. Mask is the order of the day, so everybody is tuned to that. So they can wear mask and they can go. So for the prevention, nowadays we have got very good vaccines. And one vaccine she has mentioned, pneumococcal vaccine. So that is available now. Previously we had PCV 13 and PSV 23. Now of late we have got a single dose of PSV 20 that is in the market, little costly. Single dose will give lifetime protection. And of course annual influenza vaccination. And the other vaccine which senior people should take is herpes zoster vaccine. And preventive mechanisms for these bedridden patients, of course, if possible, they should sit up and they should do some sort of exercises. And if possible, people should go out in wheelchair and should get exposed to atmospheric air and all. So this sort of breathing exercises they have to comply.
Thank you, Doctor. Dr. Jyotish Nair. Lifestyle diseases such as diabetes, hypertension and heart diseases are increasingly common in the elderly, often in combination. From your experience, what are the most effective strategies, medical, nutritional and social, for preventing and managing these conditions in a way that improve both longevity and quality of life?
As we already mentioned, the three factors, the preventive as well as the social aspects and management. So as we have said previously, the incidence of diabetes, hypertension and everything is increasing nowadays. We start seeing it from even at 30s and all. And even from childhood, we see it from 18 years because we are exposed to more than 18 years of. So starting from 18 years, we are seeing it more commonly nowadays. The best part is a combined approach to see that we maintain a healthy lifestyle, because as we have said, it is lifestyle disease. So lifestyle is the most important thing to start with. When we say lifestyle, it is diet, exercise, and also the emotional factors which we will be coming to. So diet, we have to start early. In our age, like in maybe 23, 30 years back, now even if when in our children's also, now what happens is that when we are in the college, school days and all those days, we do so much of physical activity. We run around the bus, or we may be cycling, we may be walking. But once we get a job, the thing changes. We start becoming sedentary. We have more money to buy richer foods, and richer foods are mostly fat-rich foods or calorie-rich foods. They are really attractive, and we again go after them. So these lifestyle changes have to start early. I would say once you start your first job, you should start lifestyle modifications. And this has to be continued for life. It's not just that you take the lifestyle changes for 1 year, stop it, then again restart it. No. You have to start early. You have to continue it for your life. It's a very difficult thing because, you know, most of the good foods and I would say all good things in life are either prohibited or too costly. That is what it is said. So good sweets, good fruit, good food, everything. They are really good, but it is
Nowhere to stop.
yes. So that is the most important thing. You know where you have to stop. Because yes, mangoes are really good. They are really sweet. One of the best natural things without much of coloring and artificial and all those things. But the problem is it is very rich in calorie. So you can take a piece of it, but you can't take 1 kilogram of it. It's very sweet, it's very tempting, very difficult to stop at that. So most of the things like that. So that is one thing. Lifestyle modifications have to start early. They have to be continued throughout. Second part of this is exercise. Exercise as tolerated. At age 25, you may be able to do much better. At the age of 40, you may not be able to do that much. At age 65, you may not be able to even walk properly. But what we have to do is start early again. because the muscle mass and the bone mass, they don't increase too much once you are maybe around 18 or 25. So what you have to do is, you have to be at your peak at that age and maintain it as far as possible. Decline of muscle mass and bone mass is a part of aging, and aging starts the day you start birth. So from at least 18 or 25, you have to maintain a good physical activity as possible. Some may be physically active right from the early childhood, so they may be having a better muscle and a better bone mass, so they can be able to do more enduring exercise, weight training exercise and all those things. But that does not mean that those who have not been doing exercise till 60 or 65 can't do exercise. At any age you can do exercise, but you have to know limit of your exercise. So that is the second thing. Third thing is the emotional and the other things. Again, we know that the emotional problems of the working class nowadays, they are really stressed and they are really don't have time for themselves, they don't have time to relax and all those things. But you think about all these things starting from the day you start working, so that you plan a proper aged life starting from your first job or first day at job. So these are the lifestyle changes that you have to start with. Muscle mass is very important nowadays, because we know that most of the people who suffer falls are because they don't have a proper muscle mass. So muscle is very important. You have then your again diabetes, heart disease and everything can be controlled with all your medicines and all your interventions and all those things. So that leave it to the doctors. You go according to what they are saying and do what you have to do.
Thank you, Doctor. Dr. Anusree, families are often the first line of care. What practical advice would you give to caregivers on maintaining their loved one's health across medical, mental and social domains, while also caring for themselves?
Caregiver stress itself is a big domain that we have to identify as early as possible, because caregiver stress doesn't happen when the patient is bedbound. It happens very early, even before the patient is bedbound. So the problem with our society, I would say, is that we are very reluctant in asking help. So my first advice would be ask help. If you are not able to ask help, search help. So, and collaborate as well. Because for caregiver stress, what we see is it is a cycle. It's a cycle that happens with the patient and the caregiver. And when the caregiver are burned out, like when the stress is too much, they get burned out, there starts abuse. So that cycle will happen. So when this abuse starts, then the patient will go into depression, the patient will decondition, and the disease is not going to reverse, or it's not going to improve. So the cycle has to be identified as early as possible and should be broken at the very earliest. Second thing is searching for help is not an easy task. So collaborating with similar family, like asking, if you're asking a physician or asking a geriatrician, they might know people who are having the same problem and who they can ask help for. So a geriatrician definitely can help in that way as well. So identifying and breaking the cycle is as important. Second cycle happens when the son or the daughter, when she or he become elderly. This will happen. There will be a big cognitive insult that has happened. That will lead to memory loss and cognitive dementia, and they will go into dementia. So there are two cycles. One cycle is between the patient and the caregiver. Second is it's a passing to generation downwards. So the cycle has to be identified as early as possible, and we need to have more collaborative societies and collaborative living or help that will help in maintaining the caregiver, not maintaining, like breaking the caregiver stress.
Thank you, Dr. Dr. Jose Antony, if you would recommend one change to policy or healthcare systems to make integral geriatric care more accessible, what would it be?
Yeah, As we all know, currently the entire social system, including healthcare, is not that much geriatric friendly. We always talk about child-friendly systems, infrastructures, or basic systems. We may have a wash basin with a lower height in a hotel. We may have a system where you can accommodate a child in the hotel or in any institution, or even you may find places for the children in the cinema halls even. But we don't have any such system available in the entire healthcare industry or a system in the state for the geriatric people to go on. If you go to a hospital, the most geriatric friendly system is a wheelchair or a structure. So how they have to wait for a long time in a hospital. Basically, for a senior person, a senior citizen to go to a healthcare system, they have to spend maybe 1 day over there. They have issues with bladder system or bowel movements, or they may have problems with the eating or a food system and all. So the entire healthcare practices in our state should have a geriatric friendly infrastructural protocol.
Very good.
To develop with. So we have not even thought of this infrastructural protocol or the systemic practices we have to inculcate or built in that system. For example, if a senior person is there, how to take care of them. And we have lot of technological advancements for maybe the adults or children and all. But these systems are not that way coming in the sector of the geriatric people. So these systems are to be built in as practices also. It's not only in policy, we have to bring that in the practices. And also the system should become aware that old age is not a single phase. We have a phase where a senior person can be independent, a senior person can be assisted, a senior person can be bed bound. So these phases are to be really inculcated with a conceptual understanding and policy thinking. We have a senior citizens policy in Kerala, but it's not conceptually really worked up with this different phases in senior care systems. And also another very important thing, one very important policy change, and that has become a law regarding the asset transfer of senior people. As Matthew Bramsar has said, don't give away your assets till you both are alive. That way. That means if a spouse is alive, let it be with them, and they can have a power of autonomy, or they can have the system. I may take a sentence in Malayalam. പണ്ട് കാരണന്മാർ പറയുമായിരുന്നു, എൻ്റെ കാലം വരെ ഇതിനുള്ള മേലാദായം എടുത്ത് ജീവിച്ചോളാൻ, അത് വിൽക്കാൻ ഉള്ള അവകാശം മക്കൾക്ക് കിട്ടില്ലായിരുന്നു. That means our children have a right to live with what is being cultivated in our land, but they should have this property right only after that. And because it's a right of the senior people to have this dignified living. So in geriatric care, they need not be at the mercy of somebody for their medicine, their food, their clothes, their basic services with. So these systems are to be brought into the healthcare industry, the healthcare sector, as well as with the system. Another very important thing, as Sujit sir was talking about, the lifestyle changes. Nowadays, the local governing system, PRIs, are bringing in open area where people can come, do some of their physical activities, exercises, and they can gather there, they can talk sometime, they can have a cafeteria model working, coming up in the in the PRI systems. They have smallpox.
Yes, in Bombay and all, we've seen the Nana Nani parks.
Yeah, Angamali municipality has really brought in smallpox, where they can walk a bit, they can do a small workouts in public, they can have a cafeteria where they can have a cup of tea with the system. And very important thing, the most comfortable company we all enjoy is the peer group company. Whether we are in the childhood or in the teenage or in the adolescence and in the adulthood or in the middle age or even in the old age, the most beautiful thing with us is our peer group belongingness, because we can better connect it, we can communicate better, we can understand better. So systemically we should have a system, a practice where this people have more connected systems working up with. So policy wise, I think these changes can be brought in, as well as programs and practices can be brought in.
We have a few questions from the audience. Any one of you could answer. Are there any specific interventions for promoting elderly women's health in Kerala or India? Any specific interventions, or that means programs maybe, for promoting elderly women's health in Kerala? Interventions must be programs. They must be meaning programs.
No, I don't think that there is any program in the hospitals, but in the society there are a lot of programs in community.
I think there are
women-friendly programs are there.
I think we have a concept of Snehida working. We have people who can really accompany a senior person in distress or facing an atrocity or a violence. We have legal procedures legal safeguards to work with them,
for the elderly,
socially, mentally, and also with the physical system. PRIs have public, that means Panchayati Raj institutions have these systems to work with. And also government systems have many programs where people can be brought into medical care, people can be brought into social rescue systems, or they can be really taken into mental health systems. So there are specific agencies or maybe systems working with the women's networks also.
I think this answers the second question also, which is the same thing about women's health. Which type of interventions are more practical for improving elderly women's health? Community-based interventions or psychosocial? I think you've answered that.
These are available with. Because this is very important. In Kerala, specifically, aging is a serious concern with women group.
Yes.
So there is a gender aspect for aging in Kerala. I had a very micro study with my village, that means my residents association. When I used to have this widow pensioners or old age pensioners bringing their applications for life certification systems. My panchayat member used to collect these applications and bring to me. Once I had more than 50 applications to sign it, to attest it. When I looked into that, majority of them were women. So I made a small inquiry about my neighborhood, and that was a wonderful understanding about the entire Kerala scenario coming in. That means I had 5 male people without a female spouse, and around 45 female in the age group of 60 to 90 without a male partner. And they are at the mercy of the children and or society. So we need lot of systemic programs coming to be brought in specifically for women. Another concern, women may not go for health regular checkups or practices, because that is the tradition in Kerala. If a male has a sickness, the female will take care. And the male has to own up everything, and the female will get the leftover of. Yes. So this system is really a problem
It's
with
all over India, I think.
Yeah. So these are the issues we have to work with.
We have to work with. And the next question is, what are the nutritional support options for elderly individuals with speech and swallowing difficulties? I don't know if Dr. Anusree will be able to answer that.
Possibly this should be a bed-bound patient or somebody who's having a post-surgical laryngotomy or something like that. So there are a lot of options now.
Or just weakness also? Severe weakness.
Okay, so then I would just classify that for just weakness or fatigue, unexplained fatigue that comes with aging. If they are not able to meet their daily allowance, then we can definitely add supplementations like protein powder, because most of the patient, they will be having some amount of dysphagia that is associated with aging. So most of them, they might not be able to have solid foods. So we can give them semi-solid or custard consistency food that can be a mixture of some rice or some vegetables that can be mixed in a mixie and then be given in semi-consistency or semi-solid form. Now, if the patient is again not able to swallow because of a secondary illness like a Parkinson or things like that, then we again have to classify them how debilitating it is. So usually there is a dysphagia clinic which we can send them, and we can do a
there's a dysphagia clinic.
Yes, there's a dysphagia clinic. Most hospitals do have, and they do a video laryngoscopy and everything, and then they'll just see where is the obstruction happening. Is it curable, treatable? If it is curable, treatable, then definitely we can go by that. If it is not, then we can counsel the patient. What do they want actually? So if the patient is willing for riles tube insertion in a long term, especially bed-bound patient and all, we can go for that. If it is dementic, not agitated patient, then PEC insertion, such things are also available as of now. So a lot of options are available. We just have to counsel the patient, the complication, the risk versus benefit, and the things that are available in the market also. So accordingly, the patient profile we can definitely give.
Thank you, doctor. The second one is, which type of well-being, physical, mental or social, can be considered more important than the others? All should be.
All of them have to be given equal importance, because all of them are risk factors for lifestyle diseases, and all of them have to be tackled properly and taken care of so that they don't create a problem, because each one has got its own potential to create a problem, and with when they get together, it's more difficult. So individually you have to tackle it, but see that all of them are tackled.
Thank you, doctor. Now in one sentence, I would like each one of you to answer, please. What is your personal vision of graceful aging? It's a common question to all of you. Just one sentence.
Everything has been said by Dr. Mahati Abraham. Accept aging. That's all what I have to say. And aging is not a problem as such. 20% of our the whole population in Kerala by 2035, 20% of the whole population in Kerala is going to have senior citizens. So it's a fact. We have to accept it gracefully.
I would rather say, plan for your aging, because everybody is going to age, and we have to plan for that. So planning doesn't start right at 65. You have to have an economical background. So you have to start saving for your end of life. Don't save for your children. Save for yourself. Your children are not going to take any of this. Some of them may be interested in your savings, but ultimately save for yourself. Secondly, maintain a good health. Do your dieting, do your exercises and everything like that. So maintain a good health, including your muscle and bone. Take care of your muscle and bone. Third thing is the emotional part. As sir has said previously, and our panelist also has said, you maintain a good friendship, maintain this friendship throughout your life, and that thing. And one thing that I would suggest is, start learning a new skill, maybe by 40 or 50. And if at 60 you want to learn one more, you learn one more. So you learn something that you are interested in, because throughout your childhood, your youth and all those things, you have been sidetracking all those things. You might have wanted to learn music. You won't have had time for that. So something or something might be there. Indulge in that. Learn that, practice that, take ahead that. Not that you're going to practice or something like that, but just to see that there is something with you. And finally, when you're 65 or 70, do have the plans for tomorrow also. Even though sir said don't plan for tomorrow, I would rather say plan for tomorrow. Thank you.
Thank you, Doctor.
I would absolutely agree with both the sirs. I would like to add one more thing is dignity. So
Very important.
Very important, because I think just like accumulated deficits in the body, there is accumulated wisdom as well. Like we all say, geriatrics is like pediatrics, except that we are not dealing with a child. We are dealing with a fully formed human who has their own opinions and choices. So most of the, when I see patients, whatever their caregiver, they come and tell, my father is not doing that, doing this. So I would always ask them, have you ever asked these questions to the parents? Have you confronted what their problems are rather than assuming things? Because mostly the patients who come, they do have a refined opinion about what they want to do. It's about how feasible we can do that for them. So their choices matter, even if it is about the good dress that they want to wear. So dignity actually matters when aging is concerned. And second is ageism. Like we always have that tendency to tell, now you're elderly, you don't have to do this. But I think elderly senior citizens has to be utilized in a very good way, because they have a lot of wisdom that they can definitely transfer to the younger generation.
It's a huge resource.
Yes, a huge resource, and that has to be utilized. So that also require a lot of identification and paying big respect to them, and then knowing and understanding what their needs are and acting accordingly to that. So for me, that is what I believe is graceful aging, along with these.
Thank you, Doctor.
I'm also adding with the 4 versions we had. Sir, Matthew Braham sir has given a wonderful lamentation on this particular phase of life. And we were also deliberating different dimensions with. And I just, my words may be concluded like this. I consider aging in 3 dimensions. One is natural aging. We all have to undergo natural aging. Whether we try to prevent it or we try to manage it, it has to happen with natural aging with. Second, I believe it is comfortable aging. So all medical services, physical services, good food, good medicine, care, all these things make us comfortable. So this natural aging can be made into a comfortable aging. And the third dimension, I believe, is graceful aging. Natural aging happens. Comfortable aging others can make for us. But graceful aging is absolutely our choice.
Correct.
Absolutely our choice. So how we make graceful aging? This graceful aging is something which I believe on these 3 pillars. I have hope. I am confident. I am connected. So the most important skill I require is my guts to reconcile. Maybe my children are not really doing what I am expecting. Maybe my neighbors are not doing it, my siblings are not doing it, my network is not doing it. But how I really give myself to a position where I'm ready to reconcile. Sometimes when I really talk to people, senior people, very senior people, I definitely ask them to give a call to your beloved person. May not be in the network for last 10 or 20 or 15 years. Because my daughter has gone after her interest at her youthfulness, so I'm not connected. So if possible, get connected. So that that existence of being connected, and I feel that I have done, as St. Paul, as he has rightly quoted, I have finished my running, or I have really completed my race. So I'm eligible for my crown. That crown may be socially dignified, accepted systems. It may not be something which is in heaven. I don't say that. So WHO has given a beautiful meaning to the concept of health now. They have talked about physical, psychological, and social. And now they are really trying to talk about spiritual. And that spirituality is not, as he said, not religious, not ritualistic. Rather, that spirituality is based on these three words, I believe: instilling hope to patient, hope to people, making confidence to in their mind, and getting them connected with.
And only one,
So that is what I have to
only
talk
one
about.
sentence. If health is permitted and wealth is there, travel extensively.
Yes, I agree with you. Thank you, doctors. Today's discussion has shown, we'll conclude, has shown us that caring for elders is not just about treating illness. It's about creating a supportive environment that nurtures the body, mind, and spirit. Integrated care requires teamwork. Doctors, mental health professionals, social workers, caregivers, and community leaders, all working hand in hand. This is the true meaning of our theme, Together for Graceful Aging. Luckily for us at Bless, we have these caregivers and the nursing, a very dedicated core nursing staff who really, train even the other caregivers and take care of us so well when we need it. Let us leave this room inspired to break silos, build bridges, and ensure that every elder can live not only longer, but better. Thank you. Thank you all, and thank you.